and helped found our sports medicine group, I always like this quote: "We're all athletes. Some of us just aren't in training yet." And I try to treat all my patients like they're athletes. Um, this was an interesting, just a survey that they did of Ironman people, and I think it's important to understand. You want to find the cause of the injury, not just treat the symptoms. In the United States, there's over 10,000 deaths from NSAIDs per year, and all these athletes take NSAIDs, and I have John Mortimer's name there on that slide. Um, John was a steeplechaser, ran for Michigan. He was a national champ in high school. He got renal dysfunction, and his doctor figured out it was from all the NSAID use he did over the years. So I think that's one thing. People think, oh, let's put you on an NSAID. It's going to get rid of your inflammation. And it doesn't quite work exactly like that. So if you have Achilles tendonitis and we say itis is an inflammation, you take an NSAID and you think it's going to make it get better, and it's just treating the symptoms. So I don't prescribe NSAIDs as a rule. I will tell people to maybe take Motrin or Advil for a couple of days, and that's about it. Beyond
Showing
that, you got
our
to try to figure it
ignorance,
out.
excuse me, what is the NSAID?
Oh, I'm sorry, non-steroidal anti-inflammatory drugs. So Motrin, Advil, aspirin are all in that class of drugs. And I believe there was actually 17,000 deaths last year in the United States from those drugs.
Wow.
They're over the counter. People think they're benign. These are some of the myths I think that we encounter. Patients will come in and say to me, well, I heard I can only get 3 cortisone shots in my lifetime, or 3 cortisone shots in one area. And that's not true. Um, People will say, oh, I just ran. There's no way I could have a broken bone. That's not true. When we run, we get endorphins released, and that's a powerful painkiller. Orthotics are not a panacea. As a podiatrist, sometimes in my profession, the first thing that happens when you walk into the office is you get a custom orthotic. And I don't think everybody needs them. In fact, most people probably don't need them. I rarely prescribe them in advance of an injury. Occasionally I do, but I do use them, but for the right person and judiciously and not just have it be the only treatment. Um, Rest and immobilization, I think, are always a good are always a good option. I don't like to immobilize in a boot, but that rest part I think is more important. And stretching, a lot of the studies say that stretching won't prevent an injury. Studies will show that stretching helps an injury get better, but I think stretching can only help you. It can't hurt you in most cases. So I'm a believer in stretching. And I think, you want to do an active routine before, and static stretching has its place sometimes. When someone comes into me and they're injured and they say, when can I get back to running? These are some of my rules. You got to be able to run without limping and run without pain. And I used to say to my patients, oh, do you think you're compensating? And they all say no. So you have to ask, are you in pain? Do you feel pain? And if they're in pain, they're going to compensate, and the compensation could be worse than the original injury. If they're swelling, that's a bad sign. If you have a swollen Achilles, you probably shouldn't be running on it, regardless of how much it hurts. You got to figure that out. Um, Pain should not progress during a run, and pain should not be worse after the run of the next day. So the one thing I'll have people do, especially coming back from a stress fracture, is have them hop on one foot. So if they have plantar fasciitis, or they had a tendonitis, or they have a stress fracture in the lower extremity, running is just a series of hops. So if you can hop on one foot, then that's a good sign that maybe you're better. These 2 cross-training tools I think are great. I think the elliptical bike, which my wife is demonstrating there on the left on our Pinellas Trail, which is a great 47-mile bike path that we have near our house. That machine I think, is the closest you can get to running. I know Meb's always been a big proponent of it and used it in his training. And then the Ultra G treadmill, now there's another company called Boost, which makes a similar product. Ultra G is one of the best tools. If someone has a stress fracture, especially, or healing from a surgery, even on a bone, they can get on that Ultra G and run um, and be pain free. And it's also a good guide. If you can run at 91 or 92% of your body weight on the Ultra G, then you can probably run outside. And if for those that don't understand or know about this machine, this runner is zipped into an apron that creates a seal, and you can offload as much as 90% of your body weight inside that treadmill. It was in part helped created by NASA. And if you ever want to get your athletes on one, go to their website and type in your zip code, and they'll show where they are. And in my area, the local hospital allows 10 runs for only $200, which I think is great. So $20 for a run, and you can be on it for an hour. So a nice part of the rehab, I think. Um, The running shoe industry has changed so much. and there's terms that we never thought or used before. Shoe dropper is also known as the heel differential. So sometimes people just say the drop of the shoe. So that's how high is the heel height versus the forefoot. Now I started running in the 70s, and all the shoes were probably 12 millimeters then. We're 12 millimeter higher on the forefoot than the rear foot. We didn't think about stack height. I can remember in cross country at Bucknell, Coach Goulden didn't want us to work out in spikes or racing flats, and going from a 12 millimeter training shoe to a spike that has no heel. After that first cross country race, most of us, our calves hurt so much we couldn't walk. I think the differential is a good thing. Some people are going to do better in a lower drop. Some people are going to do better in a higher drop. Certain injuries like Achilles maybe should be in a higher drop shoe if you can be. A zero drop shoe is better for people with knee pain, I think. But there's different options. Stack height is how much cushioning there is. That's probably a Hoka term. Came from Hoka more than anything else. They did a lot to help change our shoe industry. I think Hoka and Ultra, who's a zero drop company, had a big impact on all the other companies because Hoka did so much business. Every shoe company has a Hoka like shoe now. Um, Stability, motion control, and neutral is not as applicable. And then there's minimalist type shoes, there are maximalist type shoes, and the pendulum kind of swings back and forth a lot. This is partly where I've chosen to go in terms of recommending running shoes to my patients. So Benno Nigg was a great biomechanist based out of Calgary, Canada. He published a lot of the great running shoe research. And if you remember the dual density midsoles in running shoes, where the inside part of the cushioning was a little firmer and it was usually gray, a different color, and the outside was whiter, that was Dr. Nigg's idea. And when he published this paper, which he said he was going to retire, but I don't think he still has, 2015, he said that dual density midsole didn't work. He also said that the frequency of running injuries has not changed. There's little evidence in the literature that pronation or impact are risk factors, despite being considered what we think in medicine. Oh, you're a pronator, that's why you got hurt. But his two suggestions I thought were great. One is the comfort filter, and that's what I tell my patients and my runners all the time. The comfort filter is, in Dr. Nigg's research, he always questioned people about the comfort level of their shoes. And what Dr. Nigg found in his 40 years of research is people that find their running shoes more comfortable have fewer injuries. And he doesn't think there's a difference between neutral stability and motion control. And that's the preferred movement pathway. Dr. Nigg says that the foot is going to move the way the foot wants to move, regardless of what shoe it's in. So a stability or a motion control shoe is not really controlling the motion of your foot. The most important thing is comfort. That's what I tell all my patients now. When you go to the running store, you try the shoes on, and the ones you found the most comfortable, that's the right shoe for you. And I also think with shoes, different shoes are going to work, different shoe companies are going to work well for different people. So every shoe company has a different idea of what the average foot type is. So some companies run a little more narrow, some are a little wider, some have more cushioning, some are a little firmer. You just got to find that right company, and there's usually probably two or three that are going to be similar. And I usually recommend to my patients, once you find that company, kind of stick with that company. This is the foot. So this is why we have podiatry. There are 26 bones in each foot, 28 if you count the two sesamoid bones, those two little circles that are right here underneath the big toe joint. So those help absorb shock. They're called the sesamoids. It's a major injury problem sometimes for a runner. But with 28 bones comes 33 joints. And so it's a very complex structure. And then we have what's called intrinsic muscles in the foot. So an intrinsic muscle is a muscle that starts and ends in the foot. So these muscles kind of tend to get deactivated when we wear shoes all the time, and when we support our arch with an insert, it kind of turns those muscles off. So one of the things that we can do to try to help prevent injuries and even rehab from an injury is to try to get those foot intrinsics stronger. And one great way to just activate those muscles is the correct toes. So that's the brand name product that's made. Dr. Ray McClanahan's a podiatrist in Portland, Oregon. Ray was a sub 14-minute 5K runner, and when he was younger, and he's a big believer in the foot functioning the way it's supposed to, and that he's a believer that modern shoes aren't good for our feet. And it's probably true in most cases, because if you think about it, Shoes are usually not foot shaped. Our foot has to conform to the shape of the shoe. And so bunions, which when you look at this picture, you can see the bump on the inside of the big toe, that's a bunion. And a bunion is in part caused by shoes. So the correct toes kind of help activate all those intrinsic muscles. And my wife has used them extensively, and she's actually helped her bunion become a little smaller. So that's one tool which people can use, which I think is great. Um, Another great tool is this device called the Blackboard, and I have that's a picture of it. There's a physical therapist from Germany who developed this, and it's a nice tool to help get the foot stronger. And there's a little video showing what's going on with that. So that motion right there, where you're going down and then coming up, is going to help activate those muscles in the middle of your foot, and it also can help strengthen the plantar fascia. There was a paper that was done not too long ago on people with plantar fasciitis, and it examined the eccentric type of strengthening exercises that we sometimes do for Achilles tendonitis. And this is similar. You're going up, and that motion of your foot, your heel going down to the ground, is an eccentric movement. So the Achilles is lengthening and firing at the same time, but that also can help strengthen the plantar fascia. So people that have plantar fasciitis heel pain, that's a good tool for it. The correct toes is something that anybody can use. That's not plantar fascia specific. And then a group of physical therapists and doctors got together in 2015 and published this article in the British Journal of Sports Medicine. And they created the term foot core. And really it was in response to all the barefoot running was going on after that Born to Run book was published by Chris McDougall. And a lot of people kind of embraced it. And the people that got into it were kind of zealots about it. And some people still are. I don't have a problem with barefoot running per se, but I don't think it's a good idea to go out and run 8 or 10 miles on the road in your bare feet. Just the environmental parts. But there's 4 basic movements here. Letter A is what we call the short foot. And what we're doing is I have a video that'll show you. You're bringing the toes in a little bit and raising the arch. The second one, B, is just spreading the toes apart. The third and the fourth ones are just opposite each other. And between those 4 exercises, that helps activate all those intrinsic muscles we saw in the other video. So this is the video that I made to show the foot core. So what we're doing is we're pulling those toes in. My arch is being raised, but there's a tendon that's right here in front of the ankle called the tibialis anterior. We don't want to see that fire. That's what I'm talking about in the video. I just didn't like the sound of that video. The second one is going to be lifting the foot off the ground, spread those toes apart, hold that pose for about 3 seconds, then grab the ground. So all the poses are held for 3 seconds and repeated 10 times, just once a day. So the third one is the lesser toe is going to go down and the big toe is going to go down and the lesser toes are going to go up. Now, sometimes what happens when you do this exercise, if you're not used to doing it yet, all the toes want to come up together. So if you're trying to bring the lesser toes up and the big toes coming with it, do it seated, and then hold your big toe down. And the same thing, the second toe is going to want to come up with the big toe sometimes. So I demonstrate to my patients how to do these with my right foot. So I'm really good with my right foot. I can't do them with my left foot as well. I'm like most people, do as I say, not as I do. So I'm a bad patient myself. But if anybody's interested in my I'll send my whole talk to anybody that'll have my videos in there. So heel pain is one of the more common injuries. So I thought we'd talk about heel pain and then maybe talk a little about stress fractures. Most commonly, it's going to be plantar fasciitis. There's other things it can be. The hallmark of plantar fasciitis is going to be have more pain first steps in the morning and more pain after you sit. Typically, it'll go away and people kind of ignore it in the beginning, but once it gets progressive, then it can hurt all the time. So that's a good picture of the plantar fascia. Dr. Netter was an MD who was a great illustrator, and he drew all these illustrations. And that's exactly what the plantar fascia looks like. And there's 2 distinct bands. There's a lateral band that will usually only get aggravated if people are compensating for the main band. So this whole white structure here is the plantar fascia. And it's really a ligament. It's not fascia. Dr. Netter called it the plantar aponeurosis in his anatomy books, and that's really a proper term. It's fascia is the thin infrastructure that's throughout your whole body. This is not that. So this structure does not have any flexibility to it. So when people get this injury, I want to stress to them, they're going to stretch the calf mainly. You cannot stretch this structure. There's no elastic fibers in the fascia. So hanging off a step or hanging off a curb or putting your toes up against the wall, in my opinion, aggravates plantar fasciitis. It's not going to make it get better. Um, it usually feels better when it's taped. About 25% of my patients will get better just doing stretching, icing, and some basic things. Cortisone shots, not a bad thing. It's not something I jump to, and I usually judiciously, depending on when we want to use it. If someone has a competition in 2 or 3 weeks, then it might be worth it to do a cortisone shot if we know that can safely get them to the starting line. ESWT stands for shockwave therapy. The E is extracorporeal, but shockwave is usually what it's called. That's really the best treatment for this injury because it helps the fascia recover and get better. The cortisone is more of a masking agent. In a study where they compared cortisone used for plantar fasciitis to shockwave therapy, the first 3 months, the cortisone group was better. And I think that's an important distinction because most seasons are 3 months. If you're running cross country in college or in school, you only have 3 months. So at that point, I think a cortisone shot might be worth something considering possibly. But the shockwave is not going to work as fast. But in that study, at 3 months, the cortisone group started to get more pain and the shockwave group kept improving. So that's really the difference. I always talk about shoes. I give those foot core exercises to a lot of my patients. That's really the main stretch that I like. So you can bend that back knee as well to access the gastroc or to take away the gastroc and access more of the soleus. So your three calf muscles are the two gastroc muscles, which you can see, and then the soleus muscle. Those three come together to form the Achilles. You get a better stretch up in the muscle. So I always tell my patients you should feel the stretch right up here where you see that that's my wife's medial gastroc. Um, so the Achilles doesn't stretch as well. The fascia has minimal stretch to it. So there was a paper that was published by Dr. G. Giovanni. He's an orthopedist in Rhode Island, and it was a really well done study. And he found pulling the toes back and taking your thumb and doing a little massage along that tendon that pops out. So what's popping out here is that the tendon that pulls the big toe down is called the flexor hallucis longus tendon. So you pull those toes back, do a little stretch massage in there, and that can help it get better too. That's another thing that I have for my patients. This is taping for plantar fasciitis. I use kinesio tape and sometimes dynamic tape. Dynamic tape's a little newer. I like dynamic tape better for plantar fasciitis. I like kinesio tape better for maybe a medial tibial stress syndrome or shin splint or an Achilles. The dynamic tape's not as stretchy. It's a little bit more supportive. But there's proof in the literature, and one of my sports medicine mentors told me plantar fasciitis almost always feels better when it's taped. So for me, I tape everyone that comes in if I think it's plantar fasciitis, and then the next time they come back, I want to know if that tape helped or not. And that's something that's important. You want to make sure that you have that proper diagnosis. This is just a little picture from a study that they did comparing dynamic tape to KT tape with people with plantar fasciitis, and the dynamic tape people got better more than the KT tape people did. But with KT tape and even with dynamic tape, I don't think that this tape is as supportive when you do it this way. I prefer that way. And I have a little video that I send to people sometimes if they're going to tape themselves. And here it is. So we'll just run this and I'll show you. So the strips are going to be about the width of your foot or a little bit longer. And what we're going to do is split that piece of tape right in the middle. And you're going to open the tape up and leave about 1 inch at each end. And this is the concept for kinesio tape no matter where you use it. You don't want to have any stretch in the beginning and no stretch at the end. And what the experts say is you want to have a 50% stretch. Nobody knows what 50% is. So less stretch is better. So there's one brand that has little hexagons on it that go to equal sided when you get to 50% stretch. That's the TheraBand brand, but all the KT tape brands are pretty good as long as you don't have an allergy. But so there I'm leaving about 1 inch. I'm going to stretch it, start right at the heel. And then what I do is kind of put my thumb right there where that last piece is, because if you peel it off, there'll still be 15% tension. So I want to take away all that tension on the two ends. And then the next strip is just going to go right in front of that first strip. And this is easier if someone tapes it for you. So, if you have a trainer, if you're a coach in a school, that's a better way to do it. But some people don't have anyone to help them at home, and I think it's a good idea to tape it every day while you're in the injured phase. There's no downside to it. In fact, I had a patient, Joe and I ran against each other in college, and he was a great runner. He ran 217 at Boston, but he had plantar fasciitis, and for some reason he didn't want to get orthotics. He said, "I'm old school. I don't want orthotics." I showed him how to tape his foot, and he taped it every day for 2 years until his plantar fasciitis went away. So, it's a pain to do sometimes, but it can work really well, and there's not much downside to it. And if it makes you feel better, I think it's worth doing. And tape is interesting. Tape works via the proprioceptors in your body and tricks them into thinking you're more supported than it is. So most of my patients, regardless of the injury, leave my office with being taped.
Can
These are two shockwave
just
machines, two different types of shockwave that I
Dr.
use. The top
Fulham,
one is called radial
Dr. Fulham,
shockwave. The bottom one is called focus shockwave. Most
Brian,
people
can
do.
we, yeah, can we
Can't hear
focus
you.
on plantar fasciitis for a minute?
I'm
Can,
sorry, Sue. I couldn't hear you.
can we wait a minute and focus on plantar fasciitis for a minute?
Sure.
Okay,
Sure.
so let's go back a little bit on that. So that taping that you showed with the black, that seems to be an easier tape job for, let's say, a high school kid or a place that doesn't have a fancy training room.
Yeah.
Would you
And
agree?
that's exactly the one that I was showing in the video too. Yeah, that I definitely is easier. Yeah, I
Okay.
prefer this one because I had a patient come in the other day and they said, "Oh, I was supposed to put something around below the ankles, and then I had a crisscross." And I was, this is much
Yeah.
simpler.
So it's a matter of just you're holding that area up or
Yes,
pulling it up, I should say.
and yeah, and it's really that the sensors in our body, the proprioceptors, get tricked into thinking your foot and body's more supported than it is when you tape it.
Okay. Yeah, and everything that you were describing with the toes, ironically, is what I'm going through right now because I'm
Oh
coming off
boy,
a Achilles tendon rupture. But it's a year and a half old, and so you don't want your athletes going that long. But that whole toe stuff has been amazing to me because I just never realized how important the toes were. Now mine curled up because of the boot. So
very common.
why would a runner, let's say a high school or college athlete, why would their toes be affected? The shoes?
Yeah, the shoes turn off all those intrinsic muscles, and the orthotics turn off all those intrinsic muscles. And in your case, and anybody that's injured as an athlete, when you get injured, those little proprioceptors get damaged, and when you're in a boot, it's even worse.
Yeah.
Where do you get that tape? Uh,
Oh, that kinesio, you can buy it on Amazon. So the kinesio tape and the dynamic tape you can buy on Amazon.
so
That's
which
usually
one?
where I
Which
recommend
one
it.
is this one?
This one's the kinesio tape. I didn't put a picture of the dynamic tape kind of they don't have the unique one. They have a unique tribal kind of look to the dynamic tape, and it's just it feels a little bit more like plastic on the end instead of cloth, and it doesn't stretch as much, but it looks and feels a lot like kinesio tape, but just more supported.
Is there a specific one for the foot?
No, it's the same tape you can use it for everywhere.
And I think KT is a USATF sponsor
Yeah.
because they give out a bunch of freebies at
Yeah, I
certain
think they're a
meets.
USOC too, because I remember like the volleyball players, one of the volleyball players is on the box.
Oh, yeah.
Misty,
Yeah.
Misty
So
Trainer, or yeah, one of those.
I try to grab all the free samples I can with that, when you don't have facilities. But is there a way to prevent plantar fasciitis?
I think the intrinsic muscles and strengthening your calves. So doing the foot core stuff or using that blackboard. The other thing that I think can be helpful is to do some barefoot work. So whenever I coach, whatever athletes I coach, we get on the grass and run barefoot. It's easy in the high schools. After practice, we just get on the grass in the football field and do 5 times a barefoot stride.
Yeah.
But
The other way is the minimalist type shoes. there's studies that show that if you wear, like a Nike Free shoe or the company Zero or the company Lems or even those barefoot shoes, your foot has to do more work. And ultimately, if you're not injured, it can help strengthen them just to walk around in. So I usually wear a minimalist shoe to work just to be when I'm on my feet at work, then my foot's doing some work.
Now, when you say
How about
minimalist,
the sand? How about the sand work?
Yeah, no, sand works great too. Yeah,
yeah, so any of that foot stuff that we've talked about over the years,
absolutely.
definitely. Minimalist shoe, what exactly is that?
If you remember those 5 finger barefoot shoes,
Right.
that's a minimalist shoe. So companies are charging over $100 for a shoe that has almost nothing to it. But it's basically just a shoe where the bottom is the only part of the shoe. There isn't any stack of cushioning. It's just the sole and the shoe.
Now, I had a physical therapist tell me Hokas were terrible because they were too absorbent and that the foot wasn't getting a good enough push off of it. Is that correct?
Um, in theory, yes, but I don't think that makes it a bad thing for some people. So I think different shoes are going to work well for different people, and I wouldn't say that any shoe is necessarily bad for in general.
Okay, so
I don't
just
think Hokas are bad. Yeah, I run in Hokas sometimes.
okay. Do any
Yeah.
of you others have questions here for Dr. Fulham on what he's been talking about? You all are in good shape? Oh,
Dr. Fullen, what do you
Yes.
think about oh shoot, a Mo board? Dang it.
Oh, is that that's kind of similar to that blackboard, right? Is that Jay Desari's
I think so,
device that
sir.
he
Yeah,
invented?
it's
Yeah,
got
yeah,
a,
I love it. I think that's a great device too.
now what is that called?
It's like kind of like a wobble board and it's got a hole in it for the big toe to kind of go down. Is that right,
yes,
James?
sir. I think
Yeah,
it's
yeah,
a
yeah.
Mo board or
Yep.
mobile MOBO board.
Yes. I
OBO.
And
think that's a good device too. Any of those devices that help mobilize your foot and make it function better, I think are a good thing.
Okay, good. Yeah, I mean, that's the thing. Coaches, as you have questions or specific or general, please either raise your hand or, you know, ask them definitely. So you don't forget them as we go back.
Can
I
we
got a, I got
can
a
we ask at
question.
the end?
You can ask at the end, but I'm just trying to get,
Okay.
as the topic is fresh, ask, if you can. But obviously we'll ask at the end too.
Perfect.
I've had
Okay.
a couple bouts of plantar fasciitis when we had to switch shoe companies with our distance kids. And we had to access our team podiatrist literally is across the street from our university. And we got them on that shockwave therapy, and that was gold.
Yeah.
Okay.
Sometimes people don't recommend shockwave right away, but it works better and faster when you do it right away.
Yeah, we were in season, and at a university, people are freaking out when they're not able to run at conference, and probably high school too.
Sure.
But just to have access to it and was a game changer for us.
Yeah, that's great.
With this guy, and we didn't have to put anybody in orthotics, which I'm not necessarily opposed to. I've had them throughout, but back in the day when I was running, when dinosaurs roamed the earth, basically the shoes had, and I'm talking about like mid to late 70s, 80s, 90s, and they had like no support. Like, remember those old, and it was before Asics was Asics, but those Tiger, basically they were racing flats. I ran my entire cross country career in high school in those shoes, and I never got hurt.
Yep. No, my first running shoe was the Adidas Country. It was leather and it just had like one layer of rubber on the bottom.
I basically tell the kids, because they're showing up with the big, the Hokas and the Nikes with the
plate.
carbon plate and everything.
Yeah.
And I'm just like, I found a pair of those, picture of those shoes, and I said, this is what I ran in, and I never got hurt.
Yep.
Those Adidas ROMs, you could nail nails into the wall for your pictures with those.
That's right. That's right.
Let's see.
Al, you remember those shoes I'm talking about, right?
Oh, yeah, yeah. I was
Jeffrey,
running
did
in
you have a
the
question?
60s and early 70s. Yeah.
Oh, yes, I had a question. Does having a flat foot make you more prevalent to these plantar fasciitis?
Yes, I think a high arch foot and a flat foot are more susceptible to plantar fasciitis, without a doubt. So that's where sometimes if the foot is so far deviated from average, then that's where maybe sometimes an orthotic might not be a bad idea.
How about this tape?
Yeah, I love the tape. I mean, I think everybody, that anybody that has any kind of injury, I coached in high schools for 6 years and gave it up last year, but I remember one of my kids had IT band syndrome and she couldn't run. And one day I said, well, let me try to tape you before you run. And she ran 4 miles pain-free with KT tape over IT band. And I didn't expect that to be the case, but the next day she came back, she said, Coach, you got to tape me again. And when I was taping her, one of the kids said, what's that? And she said, it's magic tape. So yeah, I think any kind of injury is not a bad idea to use. You can use tape for different injuries, and it can help make a big impact for you.
Good. Bazemore, you've got a question.
Bazemore.
Where'd you go, Adrian?
Yep. Sorry about that. I was driving, so I had to switch up. Can we go back to the orthotics? Because I know you were talking about actually a couple questions. You said something about the orthotics.
Yep.
And also, no, I guess I want to hear what your thoughts about orthotics is, because I mean, I've had several injuries myself, and obviously I don't use them anymore. But everyone that knows me, I worked from everyone from high school to post collegiate. So of course, I want to be at least be able to tell them, you know what I'm saying? So.
Sure. No, this is a good example of an over the counter that I like. Power Step as a brand designed by a podiatrist. So that's a good thing to start with sometimes. My belief in custom orthotics is typically I'm not going to use them unless there's an injury history or they're injured, and I think that the orthotic is going to make a difference. These are 3 different kinds of orthotics that I've made in the past. I do use a 3D printer and make them in my office now with a 3D printer, which that technology has been great for me. But sometimes I'll try 3 different kinds of orthotics for people to help them. But it's something that I think can sometimes be useful. There's a pro group that I treat a lot of their runners, and I've probably made orthotics for most of them, but most of them after their injury problem is over, they stop wearing them, which I'm not opposed to. But I think a couple of things that I tell my athletes when they get orthotics. Number one is if you're not injured and you have a running injury, and that's usually when it bothers you, you don't have to wear those orthotics to walk around in. In fact, I prefer they don't, and just use the orthotics when you run. I rarely make them for racing shoes. Sometimes I do. Sometimes people want to have them in their racing shoes. More of a training thing for my patients, I think. But I think there's a lot of factors as to whether it's a good idea for the athlete or not. Number one, it shouldn't cause another injury. Number two, they have to be comfortable. If they're not comfortable, then they're not going to work very well. But it's varied. I think they can be very useful. I don't think everybody needs them, but if you have an athlete, especially who's tried a lot of different things, then an orthotic might be worth trying if it's a biomechanical type issue. So if their foot's a little off, and I tend to use them more for injuries there where movement like this in the frontal plane, that's where they're going to affect more. So generally, if someone has an Achilles tendonitis, I don't think that has as much to do with the frontal plane. That's not an injury I'm going to push people towards an orthotic. More plantar fasciitis and medial tibial stress syndrome. IT band is the opposite. I want to take away an orthotic if someone has IT band syndrome, because they need to pronate a little more to help absorb shock. And I agree with what Dr. Niggs said, that pronation is not evil. Sometimes we want to control a little bit, but the foot's going to pronate to help absorb shock. So I've had the experience where athletes have been in orthotic with IT band syndrome. We take them out of the orthotic and the IT band syndrome goes away. So yeah, to answer your question, Adrian, I think it depends on the individual. Sometimes it's going to work, and it also depends on the person who's making them and how good they are with working with athletes with that type of device.
Okay, thank you. The second question was that you were talking about the shoe drop, and one of the things I noticed, I mean, I'm gonna use a shoe for example, Pegasus Turbos. I love those. The shoe drop was only like what point was it 8 millimeter, 9 millimeter? But I'm a former sprinter, so I sprint with a lot of kids I work with, and that works perfect for me. But then, of
Yes.
course, you said something about Hoka, and then I see I'll go to a track meet. Coach Sue will see this, I'll tell you, it's like you go to a track meet and it looks like the shoe drop is like 20. I mean, they look thick as heck. I'm like, dude, are you wearing clogs? What is that?
Yeah. Yeah, that's so I think it's interesting because Hokas actually have a lower heel drop, but the stack height, that's the big thing is how much that shoe's stacked. That's where I don't know if the high school kids need to be in them, but because of that stack height. But I feel like older people like me that have arthritic knees, that stack height's a little better. But you're right. I think you know, some people are going to be better off in 8 or 12 millimeter, and certainly the lower stack height, having more of a minimal shoe, your foot's in contact with the ground more. So yeah, I think with a sprinter, I'd rather have them in a shoe that's more like a less cushioning, less stack height for a sprinter usually.
Now that's interesting because now for a high school kid, you're saying less heel stack is better?
It depends on the kid,
Well,
so
I mean, because you get so many, the thing that I see is these kids all show up in slides or
yeah,
Crocs.
right.
So, is what's your thought on either of those?
Just to walk around in, you mean?
They come to practice. Yeah, that's what they wear all day.
Yeah, I'm okay with that.
Okay.
Yeah, makes their foot work a little bit if they're in a sandal or a slide. I'm okay with
Okay.
that. Yeah.
Okay. We had a question too in the chat about toe yoga. Does that help shin splints?
Probably not directly, maybe a little bit, but probably not directly. I mean,
Okay.
people with shin splints, one of the things I like them to do when they're part of their active warm-up is walk on their heels and walk on their toes.
Okay. Well, we'll get to that then. Okay. Any other questions right this minute now on orthotics and plantar fasciitis? Okay.
I got one more
Marcia?
question. What if you have a student athlete that insists on having a orthotic in their racing shoe or spike because somebody told them they were supposed to do it? And I always felt like you needed that, like that you would just be slapping an orthotic. And is there ever something where you would say you need to wear these orthotics every single minute of the day that your feet are in shoes?
Yes. So I think my rule is just pain is a good guide. If people are in pain walking around and have pain during the day, then maybe they should be in that orthotic while they're in pain and during the day. If they come out of it and the pain comes back from that specific injury, then yeah, maybe they need to be in them all day. In terms of a racing shoe, usually what I would make for my patients if they wanted it for a racing shoe is something much thinner, made out of graphite, which we can make a graphite device out of 2 millimeters of material, so it doesn't take up much room in the shoe. But you're right. I wore orthotics starting my freshman year in college, and I never raced in them. I always felt like, if you're a distance running, you're running 70, 80, however many miles a week, and you're on the track once and you race for 5 minutes, then you don't necessarily need an orthotic for that 5-minute race. But for that 80 miles, maybe you do.
Thank you.
What about those insoles, like the Victory insoles that you see advertised? Are those helpful for competition?
I don't know. If you're wearing a carbon plated shoe, that's what that Victory kind of is like a little carbon plate, right? So
yeah,
the shoe does that work for you. If you want to be in a carbon plated shoe to race in, then you don't need that Victory insole. But yeah, I think whatever works for people. I've met the guy who promotes those before, and I think it's a good product for some people.
Doc, you talked about the NSAIDs. Tylenol makes arthritic Tylenol. Is that doesn't fall into the same category?
Yeah, Tylenol can affect your organs too, though. So Tylenol has some side effects as well, and so I think judicious use. I think the biggest thing you want to have people do is not take it more than a couple of days in a row. So 2 or 3 days of NSAID or even Tylenol. You shouldn't be taking Tylenol every day either, in my opinion.
they should be resting because they're hurt, obviously.
Yeah, I got to take some time off or get on the Alter G or get in the pool.
Yeah, yeah.
How
Lauren,
much are
you
the
had a
Ultra
question.
Gs now, Doc?
What's that?
How much are the Ultra Gs now?
What about the Alter G?
How much are they
Oh, how
now?
much? Oh, to buy one?
Yes.
I think for the home one, it's around 30, and for the professional ones, they're 50 and 70,000. So yeah, you can choose a BMW or an Ultra G.
That's pretty cool
But
that you can find them and go rent.
yeah, because there's a lot of people that have them. There's a physical therapist in my area that has one. It's great. I just call them up and they're like, yeah, send them over. So
That's really something. Lauren, you had a question. You're muted. There we go.
Sorry about that. Yeah, so I have a question because I've personally torn my plantar fascia, so I can heavily just feel the pain.
Welcome to my
But
club.
also I work with a lot of sprinters and jumpers and hurdlers that deal with plantar fascia pain, whether it be intermittently or more chronically. So, do you have any particular exercises that are more attuned for those type of athletes that are using, just higher ground reactive forces and things like that? Given that they're, maybe in season or it's just high demand, we got to get this training in. Any particular exercises that you seem to find are the most efficient?
I mean, I like the foot core, but for more ballistic type movements, one thing that helps a lot, I think, with strengthening the Achilles and helping to strengthen the foot is jumping on a mini trampoline barefoot.
Nice.
So I think that's a really good tool. And I've had athletes before where I'm like, listen, you got to get a mini trampoline and you're going to use it at home. And that's what you're going to do. I think making sure that one thing I was going to go into a little bit too is any kind of problem in the lower extremity, you want to make sure your glutes are activated. So that's one thing I was going to talk about later on.
Absolutely. Thank you.
Great.
You're welcome.
Okay, well, let's move on then. Thank you.
Yeah, I just have a little bit more. So these are some of the orthotics.
This is
This
great.
is the way we make a 3D printed orthotic, so it's pretty amazing. You know, that material goes in there. It's a PLA, I think, some sort of polyethylene something, and makes about 100 layers. And that's a more minimalist device there, this one. So I think I made that one for a soccer player, so that heel's cut out, so it's a little lower drop, and that fits into his soccer cleat. So I want to talk a little bit about stress fractures. I know it's something that X-rays do not always show it. So I find that a lot of times people will come or I'll hear, oh, I got an X-ray, I don't have a stress fracture. I've had patients with stress fractures that never showed up on an X-ray. So if you're trying to figure out what the injury is, a lot of times we do MRIs. It's a good first test. I've had patients have a negative MRI and a negative CT scan, and we found the stress fracture on a nuclear medicine 3-phase bone scan. So you don't want to use that a lot. There's a higher dose of radiation with that particular test, but it's really the gold standard for finding a stress fracture. If you can find another test, that's better. But MRI is better for soft tissue. CAT scan is better for bone, for looking at bone. So this was an interesting case. I can use his name because he's talked about it. Weldon Johnson had pain in the middle of his foot. Weldon was a 2806 10K guy. And he was in Ithaca. His brother was coaching Cornell, and he called me up and said, the middle of my foot hurts. And I said, well, that's his navicular. And I sent him to get an MRI, and the radiologist read that as negative. That big black area is a sign on bone that there's a fracture. And I said, well, let's get a CT to confirm it. So that's the CT scan right there below the picture of the runners. And the radiologist said that wasn't a fracture. I think most of you can see that there's a fracture there in that bone. So I always want to look at my images too. I don't just trust the report. I've had that happen a lot lately, where the report says nothing's wrong. And I had a really good runner from my area who's running D2 now. He had 3 fractures in his ankle bone that were read as negative on his MRI. And I saw it in about 5 minutes. So that's where, you got to look at things and be real careful about making sure you're finding the right injury, because this injuries can kind of be a career ender. That's Paula Radcliffe running with Weldon. And the other guy was my patient too. He paced her, and this guy tagged along. But Paula had a navicular stress fracture that I'm all fixed. And she's talked about that in the news too. But if you go too long with that injury, you got to put a screw across it. Not a good injury. Vitamin D, I think, is something that's important. That's actually General Patton getting coming in 5th in the 1912 Olympics in the modern pentathlon in the stadium in Stockholm. But this was a good study. Just looking at the level of vitamin D is important because if you go by what the lab says normal is between 30 and 70. So if your vitamin D level is 32, they'll say it's normal. This was a study where they looked at people that had a level below 40. 44 out of the 53 patients had a stress fracture. So that means below 40 is not a good level. Here's another study that talked about you want to have it above 40. You can supplement with up to 5,000 IUs a day and get it to that level. And if you spend time in the sun, and I see this a lot in Florida, people say, why do I have to supplement with vitamin D? If you wear sunblock, it blocks all the effect of the sun with producing the vitamin D, number one. And number two, I don't think our bodies are producing as much vitamin D as it used to from the sun. So these are recommended levels of how much you can take. And for some people, it's not enough. The daily intake for an adult is 600 IUs a day. If you live in a northern climate where you don't see the sun for months on end, those athletes should probably be supplementing with vitamin D. So I think that should always be something of an athlete medical panel when they get blood work done, is to check that vitamin D level. This was another study from Finland, a place where they don't see the sun for 20 something hours a day in the winter. So they do the light therapy to help prevent the depression. But in this study, it was Finnish military recruits, and military recruits whose level was below 75 had a 3.6 times higher chance of a stress fracture. I think 75 is pushing it a little bit. I always want my athletes to be at least 50, I think is a good number. This talks about all the risk factors of stress fractures. And that bottom one, I think, is real important, and that's something we can all work on. Decreased hip abductor strength. And a lot of this research, Michael Frederickson did a lot of great research on hip abductors too from Stanford University. His research is great too, but these are all the risk factors. So low body fat for females is a big risk factor for stress fractures. Low body weight for males. So now we use the term REDS and instead of female athlete triad syndrome, because we know men can have problems with eating disorders and bone stress injuries as well because of having all the other problems. This is a good test that I do. So that's a test that I always do in my patients. And what I'm testing is to see if the glute medius and the glute minimus, which are the most important pelvic stabilizers, are working. If those muscles aren't firing right and they get turned off when we sit, then that means that the lower extremity is going to be under a lot more stress and strain. And that's that decreased hip abductor strength that Native was talking about in that study. And this is just So this is the exercise that we do to help get these muscles stronger. So there's 3 exercises, and these are 3 really good exercises that every athlete can do to help prevent an injury. So it's bridging up and then opening, closing. So the most important thing is making sure that hip doesn't drop. And I usually tell my athletes I want to build up to you can do it TheraBand exercises every day, open and close 20 times. This is the next one. So this is a crab or a monster walk. And this one, you want to get into a crouch like you're playing defense in basketball. And then you're just going to walk sideways across the room. So you want to maintain that tension. And I think it's better down around lower to the ankles, because the further away from your hips you are, the more strength you're getting from this exercise. And then the third one is just a clamshell. So clamshell is keeping the feet together, open and close the knees, and that's activating those gluteal muscles. So those 3 exercises along with doing the foot core and doing some stretching are things that people can do to try to help prevent injuries in the foot and the lower extremity. And I think they can work really well. And as Native said, if you activate your gluteal muscles, then you're going to have fewer stress fractures in your athletes too, in the lower extremity. This is another exercise that my wife, who's a physical therapist, has designed for her athletes. This is a real good one. It just activates the glutes. It kind of activates all the muscles up and down that side. And it's not hard to do. This is something that I like to add to people's active routines. It's one of my favorite kids I coached in the Palm Harbor shirt. And I'm happy to send this. I can share this talk with the videos with anybody, and we can open up to more questions.
Okay. Did you had mentioned something with a shockwave or something?
Mm-hmm.
Did we talk about that? I know it was
I think
mentioned.
we did a little bit.
And then
yeah. So shockwave therapy is a treatment that comes from the same technology that they use to break up kidney stones. It shouldn't be called shockwave. It should be called sound wave, really. It's a sound wave. And what the sound wave will do is it'll stimulate healing of the tissue. It'll stimulate new blood vessels to come into the area. It'll also recruit the healing and the growth factors. So in studies of people that have plantar fasciitis, the plantar fascia will become really thickened when it's chronic. So sometimes up to 5 or 6 times normal thickness. And in the studies where they've done shockwave therapy on people with plantar fasciitis, after the treatment's done, usually about 3 months after the treatment's done, that fascia's gone back to normal thickness. So it's really helps, it's regenerative, it helps things heal. The other great thing about the bottom machine, that's a focused machine. That's more expensive. That machine is the original technology. The top machine's not really a knockoff, but the technology is a little simpler. It won't heal a bone fracture as well as that bottom one. So I had an athlete this year who had almost a complete fracture of the second metatarsal, and she's a gymnast. And after 5 treatments with the shockwave spaced a week apart, a month after that, she was able to go back to competing. And we were looking at possible surgery for her. So the shockwave therapy is a great thing for multiple injuries, soft tissue injuries. And if someone has a focused shockwave machine, that can heal a stress fracture much faster. I had an athlete last year who was a good high school female runner. She had a stress fracture in her fibula. And I did 3 shockwave treatments on her. And the 4th week, she was able to run. And then she ended up getting 7th in the state meet. Wow. So shockwave therapy can be a game changer for athletes. And I think it's one of the better treatments that there is available. And it can be used for just about anything in the lower extremity.
Now, does it have to be done in a doctor's office or?
So the radial devices, physical therapists have them, chiropractors have them, podiatrists have them. So those are more prevalent. The focus devices, not as many people have it. And that has to be, I believe, a medical doctor. I'm not sure about that one. I don't think physical therapy offices have those types of machines, the focus ones.
Okay. Jim, you had a question.
Yes, sir. Yes, ma'am. After a post-acute injury, doctor, heat or ice, which is there a better modality?
Good question.
I've heard that heat, you want the blood flow to increase, which would be heat, and then blood flow increases swelling. And I'll be quiet and let you talk because you know what you're talking about.
Yeah, the science lately has been saying don't use ice. So it goes back and forth. I've seen it in my career that it's gone back and forth. So sometimes people react to 1 study or 2 studies, and I always tend to think maybe that's not the best thing. I don't know. I still use ice after an acute injury myself. A lot of times my athletes, I'll ask them what they feel better, and I'll give them the option. So if they feel better with heat, then I'll say, go ahead and use heat. I like warm water and Epsom salts for certain injuries. If it's a joint, I think warm and Epsom salts can work really well. But I've always done well when I had plantar fasciitis when I rolled my foot over a frozen water bottle. Whether it was the frozen part or the bottle part, I don't know. But that's a good question, Jim. And I don't have an accurate answer to say which is better and which I prefer. I'll use both. So even for a post-acute injury, sometimes heat, people feel better with heat.
And Doc, can you go back to the hip ups and the for the two slides you had?
Mhm.
This, there we go. The first back
So you're looking
another.
at the bridge up,
Yes.
that one? Yeah,
The first one, then the second one, then without the bands.
yeah, that one.
Yep. And that's strengthening.
So this is really just this is more of a test. So the second, when they put the TheraBand around, that's more the strengthening, but this is testing to see if the glutes are firing properly. So it kind of mimics when you put that leg out and only one foot's on the table, that mimics a little bit of what it's like when you're running, when only one foot's in contact with the ground. So the interesting thing about the body is the glute muscles on the opposite side are stabilizing the other leg. So right now, the glute muscles on the left side are stabilizing the muscles on the right.
And that's
So if
that's
her
helping
right,
hips too.
yeah, yeah. So it's really this is more of a test just to see if the glutes are firing right. And those two gluteal muscles, the glute medius and the glute maximus, are the pelvic stabilizers. So if those aren't firing right, the hip's going to drop, the pelvis is going to drop when you're running, and you're going to have much more stress on the lower extremity.
How about the next two?
So that's the strengthening one. So that's the one where we're doing that bridge up, and then we're going to open and close while we keep the hips up. So that's actually targeting and strengthening. The glute med and the glute min are right here on the side. So the glute max is really the biggest one that everybody sees, but the glute min and the glute med are more important for athletes.
And she opens and closes.
Yeah. So see how her hips are staying up too. If the hips dropping, then you're not holding that proper form.
And then the next one.
Yep. So this is the monster walk. So I like, that's the clamshell. I just wanted to get that talking onto there. Yeah, so this is the crab or the monster walk. So this one's the best one. I think, this one I tell my patients, if you're going to pick one of these to do, if you say, I'm not going to do these, do this one. So this kind of gets that whole leg, and it's good for activating your proprioceptors and helping your balance a little bit when you're doing it. And it's really activating those side muscles. And that's another thing. There was Dr. Fredrickson published a paper. He interviewed all the athletes, I think at the 2000 Olympic trials, all the track and field athletes over there. And what he found was the athletes who did ball sports when they were kids had fewer stress fractures as adults. So that ball sport thing is that side to side movement, and that's where you're using your glute medius and your glute minimus. When we run or ride a bike or even swim, especially the crawl, we're not using the glute medius or the glute minimus. And when we sit in a car and we sit at our desk, those muscles get turned off as well. And that's our modern society. We sit in a car for a long time. If you have a long commute, you sit at a desk when you're at work. That's bad for our glutes. And then the last one is the clamshell. So that clamshell is just the open and close. So that band goes around the knee. You keep that top hip stacked on top of the bottom hip. You don't want that hip going backwards, because if it does, then other muscles join in and compensate. But feet stay together, and you open and close with the knees. And that's the clamshell. So I think those are the three that I think work really well.
What was the one your wife had done there?
So that's just basically a lunge with a twist. So lunges are great for the glutes as well. But that's just getting into a lunge position and that twist. And it's important to remember that we have these fascial slings, and they can affect the whole body. So adding a twist and using the upper body when you're doing an exercise helps the exercise become more functional, and it's better for your body.
Okay, let's see. We've got a few questions here. Lauren, you want to go again, and then Allison?
Yeah, so I just was asking kind of about if we could discuss a little bit about like the role that breathing mechanics can play within like preventing these injuries in terms of utilizing the glutes and the hip flexors. And how have you found in terms of cueing, especially with runners, like what are some good cues to help with some of those breathing mechanics?
That's a good question. That's more my wife's expertise, and I've learned that from her. But yeah, that's very good. I mean, I'm lucky because if I have a runner that I think has some problems like that, I can refer them to her, and she's really good at that. And she might, you want to come answer that question? All right, let's get this is Anne Marie.
Oh, we're getting
Oh,
a
Marie.
All right.
auxiliary.
Hi.
Here we go.
Hey.
What was the question about breathing? Okay. So I usually try to explain effort is with exhale. So if you're going to even just come sit to stand, that's an easier way to think about, like, you take that deep breath for the getting ready to do that effort and then exhale to come to stand. So that's just one example of the exhale for effort. But when I test people to see if they have um, the proper intra-abdominal pressure, I'll have them lay on their back, lift up their leg. And if you see this coning in their stomach, or the same thing if they're coming up, doing a chin chuck, and you see this coning in the stomach, then they're not combining the breath work with what they should be doing. So then what I do is when they lift up that leg, I'll press my hands on their hip bones, and then that's acting like that very deep core muscle. It's called the transverse abdominis. So we know the rectus is in front, that gives you the six pack. Then you have your obliques, the internal and external, and then on the deepest level, which is part of your abdominal core, is the transverse abdominis. So if I see that I push on their hip bones and now they can lift the leg and not see that coning of the stomach, that's telling us that their transverse abdominis muscle is not working. So what I do is, if you know, like a Palloff press with a TheraBand, that's a start, and then they can rotate. And when I combine the breath work, so you're taking if you can imagine, I have a band that's connected maybe to the doorknob. A doorknob is a perfect height. You take your deep breath in, and then you exhale, then you're turning. So then you're getting that, I call it almost like a girdle effect, that the stomach is working with the exhale with your breath. So that's everyone could benefit for that. So if you're just looking for general exercises to give people, like Brian was saying, like crab walks are good for the glute medius, that's not a bad exercise to give all the people. They can even use a cable column.
Doing that exercise, sorry, doing like the Palloff press, like single leg with like a really foot
love
focus.
that. Yeah,
Maybe
like
a hand under the foot would be a good.
I love combining something like that, because now you're working the proprioception with it. So then if you're doing single leg work with that Palloff press, then you can just combine the breath work. And if you even want to take it a step further, you can have them go barefoot doing that, work on what he was talking about with the foot core, spreading the toes out. And then we're incorporating everything. And you're getting your proprioception, your balance, with that transverse abdominis working, and with the effort of the exhale. So your breath work.
Awesome.
So
Yeah.
I feel like I gave a lot just now. So I don't know if you have specific
Oh, that was
questions.
great. I appreciate it. That was very thorough. Thank you.
Okay, good.
Allison, you had a question too?
Yeah, I had two questions. So you spoke about vitamin D, which is fantastic. I even know my vitamin D level living in Oregon. What other supplements would you recommend for optimal recovery? And then my second question kind of goes along with that of, what about any other alternative therapies like red light therapy, infrared saunas, different things like that? Have you seen any success with any of those things?
Yeah, I think supplements, I should have mentioned that if I have someone who has a bone stress injury or has had a history of bone stress injuries, supplement with some calcium too if they're not a dairy person. So sometimes I'll just recommend that they chew maybe 2 tums of calcium a day. That's a good calcium supplement. It has the right type of calcium carbonate, I think, is what's in that. And our body absorbs that a little better. Our body absorbs everything better from food sources. So supplements, I don't recommend a ton of them. I don't know enough about them. So I generally, in terms of recovery, I think getting enough protein, is real important. I think not monitoring calories, but making sure, especially when I was coaching with the high school kids, make sure they're eating enough. So I had an athlete, he broke 18 minutes in the spring for a 5K on the roads, and then in cross country, he couldn't break 20 minutes. And I looked at everything, are you anemic? Do you have this? Do you have that? And then I said, track your calories. And the first day he said, I ate 1,500 calories today. He was running 80 miles a week. So I was like, I had a meeting with his parents, and he wasn't trying to do it. He wasn't trying to cut calories. When school started, he stopped eating breakfast because he had to get up at 5:30, because at that point in time, Pinellas County was starting school at 7:10 in the morning. So, he just didn't eat breakfast. So I think making sure, I like that 30-minute window afterwards for recharging after a workout. Try to get, that 40 30 30 combination into your carbs, fat, and protein. I think making sure you eat enough calories and making sure you eat enough protein, and sleep. I think that's the biggest thing every athlete can do that most don't. Only the ones who are truly committed. So you have athletes who say they want to be good, and then you have athletes who are committed to being good.
Perfect. Thank you.
Welcome.
Now, you had mentioned protein after practice and 40 30. What is that?
Yeah, 40 30 30. So protein, they did a study, that's kind of where I get it from. I tell my kids to drink chocolate milk.
Right. Yeah.
Because that's that combination, 40% carbs, 30% protein, 30% fat.
So just like a little protein shake or something they get?
Yeah, or a bottle of chocolate milk.
Okay.
Yeah.
And that's for just runners or all athletes?
I mean, all athletes have that window where the body supposedly will super compensate if you eat within that 30 minutes after a workout, and it'll help you recover faster.
This protein in the morning is a big thing that I think a lot of our athletes don't do. Or, they'll get a toast, and like you say, they practice as early and they miss out on the protein, and then that is a carryover the rest of the day. Okay, other questions? We're getting some good ones here.
This is Sandra. I just wanted to make I guess a footnote, or have the doctor confirm that. Is that okay?
Sure.
Mhm.
Yeah. So circling back, I got on when you were talking about the vitamin D, and just my experience in working with some athletes. When you take the vitamin D, and I've had issues, low vitamin D, et cetera, et cetera. And it was interesting. You go to the doctor and they can give you the prescription vitamin D, and the numbers do not get where it needs to go. But I will tell you from my experience, and I had a nutritionist that worked with me that said it's very important to take vitamin D with K, because K helps the vitamin D to absorb much, much more than if you take it by itself. And I mean, my numbers were 3 times what it needed to be. And so I don't know your thoughts on that. I mean, I've had positive experiences with that, but just wanted to get your thoughts on that.
Yeah, I usually recommend, if I know someone's low and they have a bone stress injury history. So let's say I have a patient, they get their vitamin D level and it was 9, and they just had 2 stress fractures. That was my wife a few years ago. I recommend Replesta. Replesta is a 50,000 IU chewable vitamin D. You can buy it on Amazon. It's over the counter. And typically what I'll do is have people take a 50,000 IU pill once a week for 8 weeks. And that's going to boost them. My wife's vitamin D went from 9 to 46 after 8 weeks of 50,000 IUs of vitamin D. And now both of us supplement twice a month with one of those. So 50,000 twice a month keeps our levels up to where they should be. But everybody's a little bit different, and that vitamin K is a good tip to add that when you're supplementing with the D.
What's the spelling of that vitamin?
Replesta is Replesta. Lesta. And they have two versions. They have a 50,000 and a 14,000. But I think the 50,000 IU pill is maybe about $3 a pill.
Okay. Okay, other questions? We're coming up. We've got about 10 minutes left here, and we've got two doctors on our on our screen, so we can utilize both of them here, I think. Got them trapped in the hotel, so that works. Adam, do you have a question or comment?
Sure, I have a question, I guess, relating to stress fractures. Had a young lady this past spring actually roll her foot, she said, on a run. And I did some reading, some Googling, I guess. So that can cause a stress fracture in the cuboid bone is where she ended up with her stress fracture, which I read was pretty rare because it's a non-weight bearing bone in the foot. But then I guess the question that I had was, obviously, coming back, the trainers put through, their return to running. And then they eventually say, like, all right, now they're yours, Adam, but their mileage is not back up yet. So other considerations as a coach, I was very cautious with her, and she's back now, just ran her first race in cross country season. She's a big help on our team. But other considerations that you want to take, and I'm sure everyone is different with each stress injury, but of not ramping them too fast or going back too quickly.
Yeah, there's a couple of return to running programs. I think the Wisconsin one is a pretty good one. It's pretty conservative. Was that the one that you liked, the Wisconsin one, or what was the one that you liked the best? The return to running program. Oh yeah. So that Wisconsin program it seems conservative, but I like it. But with a stress fracture, it's tough to do that follow-up test to see it. If she probably had advanced imaging, right, like an MRI or a CT scan to find it, or did they see it on an X-ray?
I can't remember if it was X-ray or MRI, but yeah, she rolled it about 2 weeks out from the conference meet, and it didn't hurt that bad. Sometimes it didn't hurt at all, so she didn't mention one. Ran, took a 2 to 3 week break after the conference meet, and then started back up and said her foot looked weird and got it checked out. So,
oh boy, okay, that's interesting. Yeah, I think with a stress fracture, my usual advice is again, you got to be able to hop on that foot. If they can hop on that foot and they don't have any pain, then what I like to do is start with a short run, walk even, and then the next 2 days are off.
Yeah.
So my usual return would be run 1 day, 2 days off, run 1 day, 2 days off, run 1 day, and see how you're doing. And if that whole week has gone well and those first 3 runs didn't produce any pain, then I would go to every other day and then ramp up from there. And that's probably something like you did something similar to that, right?
Yeah, the trainers worked with her for I think first 4 to 6 weeks with controlling her return to running. But then when they give them back, their mileage still isn't like fully up. She may have run like 20 something miles in a week. At that point, is she good probably for a normal rate of return in terms of like more quickly? Because I just kind of stayed pretty conservative, with the 10% rule, and just like bumped her up very slowly so that we didn't have another like flare up or setback.
Yeah. I think if she's, let's say she's out, what would be a normal week for her? Like 40?
35 to 40 is what she ran.
35 to 40. Yeah, I think from 20, you can go up more than 10% though.
Okay.
Because 10% is 2 miles. So you can go up more than that.
Right. We did
really, yeah, I think as long as she's pain free, and you can definitely get back a little faster than that, especially after 6 weeks. Then I think she's probably fully healed and she can handle it. But I think it's smart too, because you got to remember the rest of the structures might be affected too. So sometimes people come back from a stress fracture and end up getting a tendonitis. So you did a good job.
Gotcha. Thank you.
You're welcome.
Adrian, you've got a question?
Yes, ma'am. Dang it, if my computer would work right. Golly. Okay, there we go. Doc, you said something about the toe yoga, and I was unfortunately I was trying to look and drive. Every time I hit a red light, I would try to grab the phone to. I don't worry, I was not doing. I literally waited till it got the red light, and I turned and look at the phone. But obviously, I can hear Brooks yelling at me now. Boy, just spit it out.
That's Spit it out.
Right. Well, you said something about toe yoga, and
Yeah.
obviously the flexibility, will activate certain muscles in your feet.
Yep.
Will that, and because I work with every sport that involves speed and hitting the ground, and Coach
Yeah.
Stewart talked about this thousands of times. Will that help in performance, meaning get the kid faster, jump higher, stronger, da 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 da?
That's a good question. I mean, maybe not directly, but if it helps them stay healthier, then they will. And I think the proprioception definitely will help make a big difference. And then, because that's another thing that it's helping get better. But so I like people to do these standing. So this is the short foot, Adrian. So you're trying to pull your toes in a little bit. The arch is going to come up, and you don't want that tendon right there in the front, the tibialis anterior firing when you do that one. So that's the first one. The second one is you lift the toes off the ground, spread them away from each other, and then grab the ground. You hold each pose for about 3 seconds and repeat them 10 times. And then the third and the fourth ones are just opposite each other. So the third one is the big toe goes down and the lesser toes go up. And the last one is the lesser toes go down and the big toe goes up. So I'm just demonstrating. Sometimes the big toe comes up with the other ones when you try to separate them, and it's hard to. But once you get it, you got it. So, and then the lesser toes down and then the big toe up. So it's those 4 maneuvers. And I can send you a copy of this talk to anybody that's interested in the talk. I can upload it to Google Drive or Dropbox because the videos are large. I can't email the whole thing, and I'll send you the link for it. So my email is drfulham@gmail. Dr. Fulham all spelled out.
And I've got it too, so we can
Good.
get it up there. Yeah, because these videos are great to make the visual with that. Lauren, you want to
It's hard to describe those unless you see them.
I'm sorry?
It's hard to describe those exercises unless you see them, I think.
Yeah. Lauren,
Actually,
you want to sneak your last question in?
Okay, yeah, my last question, I guess, especially because it sounds like we've got a lot of coaching and practitioner experience here. I know, especially at like the college and high school level, it can be a little bit harder to like communicate with different people within those groups. So how do you suggest kind of bridging that gap? Especially when you're like the third party practitioner that's working maybe outside of the school system or the scholastic system. How do you better communicate with the coaches that are having an impact on the load and things that are going on, especially if the kid is maybe not the best at reporting or might be hesitant to be pulled from their sport, things like that?
Yeah, that's a great question. I mean, sometimes I get coaches that send kids to me. I mean, the best school in my county, they won the state title 2 years ago, and that coach just calls me or emails me when a kid's injured and sends them over. But I've had the case where the coach would never intervene, for medically. I mean, when I was in Connecticut, there was a local college coach that would never intervene, and I knew him since we were in high school together. But that's tough. Sometimes you can't get to the coach and have an impact in terms of that. I've had that happen with athletes where I say to them, listen, I had an athlete that would get stress fractures and medial tibial stress syndrome every time she ran on hard surfaces. And I said to her, you got to run on grass. Just see if your coach will let you run on grass. And he kind of ostracized her from the rest of the team. Oh, she's not tough enough, that kind of thing. So I didn't say anything. I didn't know the coach, so I didn't say anything to the coach. But yeah, that's a really hard thing. I mean, one thing I did about 6 or 7 years ago, I gave a talk to the whole county, to all the coaches. That was run through my local running store, which is a great store in St. Pete. But that's one way I try to reach the local people and reach the coaches is that was a nice thing. The running store put it on and gave away free shoes and all the coaches came. But yeah, you're right. I mean, I think there's a lot of lack of communication, miscommunication, and sometimes to the detriment of the athlete. But yeah, that's a good question. I mean, I try to do the best I can, and if I have access to the coach and the coach is willing, I'm always happy to talk to them about it. But I always give my athletes, I try to give my athletes pretty specific instructions about whether they can and they can't run and what they can do for cross training and what's good for them and what's not.
That's great, because that's the whole thing. Sometimes the schools and the medical staff at the school get very protective and HIPAA and all of this and that.
Yeah, it's interesting egos sometimes too.
Yeah,
I had a college. I knew the coach. He had a kid with Achilles tendonitis, his best kid, and I said, hey, how about I get you a shockwave machine, get your training room a shockwave machine? And I went to the school and they had set up a couple of kids for me to look at, and the head trainer refused to meet with me.
Oh yeah.
And they didn't want to use the shockwave machine.
Yeah.
I got them a free machine for 3 months and they didn't want to use it.
Crazy.
That's so
Crazy.
frustrating.
Well, Dr. Fulham, thank you.
Oh, my pleasure.
You know, we got a lot out of this, and hopefully everybody got their questions and so forth. Let's see, are there home shockwave units, or is it more in the office?
You find them on Amazon. I don't know if they work, but I had a patient tell me they sell one on Amazon for like $600. I was like, I don't think it's going to work, but
Oh, goodness.
All right, thanks.
You never know. But
right.
Again, if you guys have thoughts for next week, let me know. VJ's dad got caught up in another talk. These guys are so popular that they do tag team presentations here. We're just lucky that Dr. Fulham didn't float away or blow away. And hopefully we're giving you the best wishes now as far as your house and
thank you.
Everything when you get back. So thanks
Appreciate that.
again. And we'll see you all next week.
Good night, everybody.
Good night.
Everyone.
Thank you.
Thanks.
Thank you, Doctor. I'm going to bombard you for a request for the presentation shortly, sir.
Please, yeah, everybody, anybody that wants if you want the presentation, send me an email. If you have any other questions, if you have an athlete that gets hurt, reach out to me. Happy to help.
Thank you so much.
There
All right.
go.
Be safe for you and your family, sir.
Yes, you
Thank
guys
you.
take care. Thank
Hi,
you,
VJ.
wife. Thanks so much.
All right. Good night.